Hi, Kimberly.
Hello.
Nice meeting you.
Nice meeting you as well.
Dr. Lukowicz should be on pretty soon. He usually joins about right at the time we start. Normally, they don't let us on until right at 4 o'clock, but it's good that we can test it out beforehand.
Yes, it made me feel much better to be able to test it before 4 o'clock.
Yeah. We
Hi,
usually,
all. I just want to let you know Andor from Georgetown Center for
hey,
Children and
Ann.
Families is here. Hi,
Hi, Ann. How are you?
I'm well. How are you?
Good. Good to meet you.
Yeah, you too.
I was just telling Kimberly it's unusual for them to let us on early. Usually, they let us on right at 5 o'clock. I mean, at 4 o'clock.
Yeah, I
So
wasn't sure what the protocol is. I thought I'd come
This
a few minutes
this is
early.
nice, and the folks at Media Services at the House of Representatives, they're great. They handle all this for all the subcommittees and a lot of other work they do, and they just do a great job. And we appreciate you, David and Patty.
And Gary, can you remind me, am I going first or second? Because I know there's two speakers.
First,
Okay.
and that's because we scheduled you first.
That works for me. Thanks.
Yeah, Roland recommended you, I guess a couple of months ago. And I'd heard also some other good reports about how your depth of knowledge goes back many years, and you have a wealth of information to share with us. And I don't know if you know, Ann and Kimberly, but the subcommittee, the Child and Adolescent Subcommittee, is one of 5 subcommittees of the Behavioral Health Reform and Innovation Commission. And the commission has been in place since 2019. And the commission has played a very important role. Georgia passed the Georgia Parity Act, Mental Health Parity Act in 2022, and much of the substance of the Parity Act came from recommendations from the Behavioral Health Reform Commission. So we have monthly meetings. The subcommittee of the Children and Adolescents, chaired by Dr. Lukowicz, who is an associate professor of psychiatry at the Medical College of Georgia. And we usually start those in May because we don't want them to interfere with the Georgia legislative session that runs from January through April. And this year, as the last 3 years, or last 2 years anyway, the commission tries to formulate does formulate an annual report that's given to the full commission in December, the first week in December. So what you will present to us today will be recorded. It will become part of the Behavioral Health Reform Commission and Innovation and Commission's annual report. And so it will be available to a lot of people. And because of the success of the Georgia Mental Health Parity Act, which was arguably the most important mental health legislation in Georgia in the last 40 years, it received some national attention. So that then brought some scrutiny to the work of the Behavioral Health Reform and Innovation Commission and each subcommittee. So there's great interest in the work. So I say all that to say that what you have to say today is, even though the subcommittee is 6 members, there will be a lot of people on the Vimeo access to the public. There'll be a lot of public members listening in and watching and very interested in what you have to say. And then it'll be part, like I said earlier, of the annual report. So we really appreciate both of you joining us today. Do you have any questions?
I do not have any questions at this time.
Okay. We'll just take a sip of water and we'll start pretty soon.
All right, sounds good.
Okay. I forgot, Ann, Ashley, who works with the behavioral health department in Georgia, will help with your slides.
Thank you in advance, Ashley. I'm happy to prompt. Thank you so much for
Unless
supporting them.
David and Patty, are you gonna do that, or are you gonna let Ashley do that? I think Ashley said she was gonna do that, but anyway.
Hey, Gary. No, it's David Bradley. Hi, how are you? Happy Thanksgiving to you. I don't know if you can hear me or not.
Yes.
Okay, great. Good. Happy Thanksgiving. No, I'm not presenting today. I'm learning from all of you guys.
Okay. And that's Dr. David Bradley, Kimberly and Ann. He's a member of the subcommittee.
Hello, Kimberly and Ann. Thanks for helping today.
You doing okay, David?
Yeah, I'm doing fine. It's been kind of running around a little bit today. Still getting everything all set up.
I understand that.
Been one of those.
It seems like when I have meetings, they all just seem to pile up on the same day. I'm not sure why that happens.
Yeah, I can concur with that.
This is the third meeting today.
Oh gosh. Well, this is the best one. So there you go.
Absolutely.
That's the goal, right? Yes. Make it the best one at least.
Save the best for last.
Great.
David, I don't know if you saw the agenda, but Ann is from Georgetown University and worked with the U.S. Senate Finance Committee, and Kimberly is from the Tanner Behavioral Health Center.
That's great. Yes, I did see that on the agenda.
There's Dr. Lukowitz. Then there's Ann and Miriam. How are you, Miriam?
I'm fine. How are you doing?
All right, good to see you.
You too.
Did you have a good day?
So far, we had the Thanksgiving feast at my daughter's school today, so
Good.
it was a big deal.
It is a big deal. That's a major deal.
All right, Gary, I know I'm supposed to talk about some statistics, but I can't seem to find them.
The ones I sent today,
Did you send them today?
the one that Ann's going to include.
Okay, let me see if I can find, maybe if I can find them now. All right.
If not, Dr. Lukowitz, I can find Dr. McGivney's email and resend it, so it's top.
I'm looking right now. Oh, here we go.
He puts all my email in junk file.
Well, no, some of them do go to the ones that come from your consultant account. They were going there. I told them not to.
Okay.
Now I see there's something about information, but mental health data, but from the GS, or the Georgia School Health something, right?
Yes. Should be an attachment.
All right, let me find here. Here it is. Okay. So do you want me to when I go over it, I should just share the page?
No, we were just talking about including that data in the annual report.
Okay, you don't want me to talk about it today?
No, not necessarily.
Okay, all right. Yeah, those are stark numbers.
Yeah.
Which is not surprising given what I see day in and day out. So okay.
Well, the important part, I think, too, is that's data from before the pandemic. So we were trending, the trajectory of mental health issues was trending upward even before the pandemic.
Right. Oh, yeah, and that was consistent with what we saw, so that's not a surprise. Okay, well, I guess in order to stay on time and be respectful of people's time, I would like to welcome everyone to the Child and Adolescent Subcommittee meeting of the Behavioral Health Reform and Innovations Commission. I'm Eric Lukowitz. I'm a child psychiatrist by training, and I'm a associate professor and assistant dean here at the Medical College of Georgia. And we are privileged today, and I've got my schedule here. I got to open up the right window here, to have Dr. Ann Dwyer. And I have let me just open up the right box. Here we go. Here it is. All right. Esquire, excuse me. I didn't mean to offend you. And now, of course, if you call a doctor Esquire, they're really offended. You know how that goes. But in this instance, you are a research professor at Georgetown University McCourt School of Public Policy, Center for Children and Families. And then, and you're also going to, we're also going to have Miss Kimberly Johnson talk about the Willowbrook Counseling Center, and Wendy White Tigring is going to also present. So let's start with Ms. Dwyer. The floor is yours.
Great. Happy to be here today. And I think we had maybe some slides. I don't know if we can get those up. I don't know, Gary, if someone on your end was gonna.
If I can, I will. So let me see. Yeah. I'll be able to. It's just opening slowly. Just 1 second here. Just trying to figure out how to put it on presentation mode here.
Yeah, Ashley was scheduled to do this, Dr. Lukowitz, but I don't see Ashley online.
Okay. All right. Well, we've got it. We've got a backup. I've got it here. I'm just got to find the button for presentation to show it. So let me just get here. I'm sure it's slideshow. Here we go. This should do it. All right. Now let me get to share my screen. Okay. I can do this. Here we go. Share screen. This is the screen. Here we go. Point slideshow. Okay. Share.
Excellent.
Can you see it?
I absolutely can. Hopefully everyone else
Now
can
let me
as
see if
well.
I can figure out how to change slides. Let's see. I'll let you go ahead and start it and see if we can figure out.
Okay. That sounds great. Well, again, thank you so much for inviting me to speak with you today. And thank you for the introduction. I'm Ann Dwyer. I'm an associate research professor at the Center for Children and Families at Georgetown University's McCourt School of Public Policy. So for those of you not familiar with CCF, we are a policy and research center with a mission to support access to high quality, comprehensive, and affordable health coverage for children and families, really with a particular focus on examining policy development and implementation efforts as it relates to Medicaid and the Children's Health Insurance Program, also known as CHIP. So today I will be providing a landscape overview of recent federal action related to Medicaid and CHIP, with a focus on mental health, including youth mental health. I'll also briefly be touching on the unwinding of Medicaid's continuous coverage requirement, which is having a big impact on children's health coverage right now, and therefore is really important part of the discussion when talking about access to services for children, including mental health care. So next slide, please, if you don't mind.
Okay. All right. Let's see. trying to figure out how to do that. Let's see. Here we go.
Yeah.
There we go.
Excellent, thank you. So when we talk about mental health care, we really can't talk about it without also talking about Medicaid. Why is this? I know many of you are likely familiar with the program, but as a quick overview, Medicaid is a joint federal state program, and it is the single largest payer of behavioral health services in the United States. And Medicaid, alongside CHIP, also covers about half of all children in the US and nearly 40% of children in Georgia. So again, if you're talking about children and you're talking about mental health, Medicaid and CHIP are really critical parts of the picture. And children covered by Medicaid and CHIP really rely on the programs to support their mental and behavioral health needs. According to the Centers for Medicare and Medicaid Services, as of 2020, nearly a third of non-institutionalized children ages 3 to 17 who were covered by Medicaid or CHIP had a mental, emotional, developmental, or behavioral problem. Yet, even though we know Medicaid is a critical coverage source and covers comprehensive care, just because a child has a mental or behavioral health need and has coverage, it doesn't necessarily mean they have an easy time accessing that care. While Medicaid coverage can provide or does provide a broad and comprehensive array of mental health services, including screenings, therapy, medications, inpatient and outpatient care, and community-based services, CMS has also noted that of children who received mental health care, 35% had either a somewhat or very difficult time obtaining that care in 2020. And unfortunately, the pandemic exacerbated many of these challenges. Next slide. What we know is that a lot of these issues aren't new. I know many of you know that as well. Even before the pandemic, we were seeing access issues for mental health care and increasing rates of mental health need across payers in many populations. But many of these needs are intensifying. As some of you may have seen in the fall of 2021, national pediatric provider groups, including the American Academy of Pediatrics and the American Academy of Child and Adolescent Psychiatry, came together to declare a national emergency in child and adolescent mental health, notably a declaration that is still in place. Around the same time, the US Surgeon General also issued an advisory on youth mental health crisis. And we also saw a number of studies come out of the CDC about increased pediatric emergency department use for youth with mental health conditions. More recently, this past spring, data was released from the CDC finding that in 2021, almost 60% of female students and close to 70% of LGBTQ+ students experience persistent feelings of sadness or hopelessness. So clearly, as we know, a lot of need in this space. Next slide, please. So what's been happening? As I mentioned, what I'll be focusing on today is an overview of recent action at the federal level related to mental health and Medicaid and CHIP, including youth. Next slide. So in terms of federal action, I tend to think about this in two buckets: congressional action and administrative action. As I'll be speaking about in more detail, Congress has passed a number of bills over the last 3 years that include policies related to mental health, including Medicaid and youth mental health. And we've also seen the administration take a number of actions through both formal rulemaking and through more informal sub-regulatory action, including the issuance of guidance documents, informational bulletins, and a recent action plan. Next slide, please. So first, we'll start off with congressional action. So in March 2021, Congress passed the American Rescue Plan Act. This was a large reconciliation bill that included a number of provisions, including those related to healthcare. I'll note that we have a helpful explainer on the CCF website of all the Medicaid and CHIP provisions included in the American Rescue Plan Act. But notably on the mental health side, the Act included a provision to allow state Medicaid programs to provide community-based mobile crisis intervention services for individuals in crisis while receiving an enhanced federal matching rate of 85% for the first 3 years. In order to receive the enhanced federal funding made available under the new option, states must meet a number of requirements, including that services are available 24/7 and that the funds are geared towards expanding services by supplementing and not supplanting existing state spending on mobile crisis services. The option became available to states in April of 2022 and currently extends through March 31st, 2027. To date, about a dozen states have taken up the option, including most recently Montana, which received federal approval for their state plan amendment last month. The American Rescue Plan Act also provided an estimated $12 billion in enhanced federal funding to states to support home and community-based services provided to individuals covered by Medicaid. Last year, we released a report of our review of spending plans and narratives for the 50 states in DC, examining whether and how states were planning to use the funds to support children's mental and behavioral health as part of their activities to enhance, expand, or strengthen home and community-based services under the provision. In that review, we found a number of states plan to invest in initiatives in support of youth mental and behavioral health, including Georgia, that included a new home and community-based initiative to provide behavioral aids in the home setting for individuals under 21 who are diagnosed with autism, to reduce the number of admissions and or readmission to psychiatric residential treatment facilities, and increase access to home and community-based services. This additional funding made available under ARPA was initially set to expire in April of 2024. However, that has since been extended by CMS to April 1st of 2025. Next slide, please. In addition to the American Rescue Plan Act, we also saw Congress include a number of provisions related to Medicaid and CHIP and mental health in the Bipartisan Safer Communities Act passed in June of 2022, amounting to an estimated $8 billion in new federal Medicaid support over the next 10 years. The largest component of that is the national expansion of what is known as the Medicaid Certified Community Behavioral Health Clinic, or CCBHC demonstration. At a high level, this Medicaid demonstration was created in 2014 to essentially expand access to behavioral health clinics that meet certain federal standards, like requiring 24/7 crisis services and routine outpatient care, and serving anyone who requests care for mental health or substance use, regardless of their ability to pay or age. The Act's national expansion opens the Medicaid CCBHC demonstration up from the previously limited 10 states to all interested states. And it does this under a phased-in approach, where every 2 years, 10 new states can join the demonstration starting in 2024. It also provided $40 million to the Secretary of HHS to carry out the program and provide planning grants and technical assistance to states. So as discussed in a recent brief we issued on the status of the Bipartisan Safer Community Act provisions, in March 2023, HHS announced that it awarded 15 states, including Georgia, with $1 million one-year CCBHC planning grants in support of state efforts to join the Medicaid-funded CCBHC demonstration program. Current planning grant awardees must submit a proposal to participate in the CCBHC demonstration by March 2024. And up to 10 of the 15 states will then receive planning grants and submitted proposals will be eligible to participate in the CCBHC demonstration program and received enhanced federal Medicaid funding starting as soon as July 2024. Notably, according to a report by HHS that examined the initial demonstration states, about 23% of CCBHC clients were children or adolescents, ranging from 8% to 27% depending on the state. In addition to the CCBHC expansion, the Bipartisan Safer Communities Act also requires the Health and Human Services Secretary to provide technical assistance and issue guidance to states on improving access to telehealth under Medicaid and CHIP, including things like best practices for telehealth in schools and strategies to promote the delivery of accessible and culturally competent care. That guidance is due by next month. The Act also requires the administration to issue guidance to states and schools to support the delivery of services to children covered by Medicaid and CHIP in school-based settings. This includes a new technical assistance center to assist and expand the capacity of states and schools to provide and bill for Medicaid services. It also provided $50 million in new federal funding for grants to states to implement, enhance, or expand school-based services under Medicaid and CHIP. To date, CMS has released a number of Medicaid school-related guidance documents, including an updated Medicaid school-based services claiming guide, and has launched a website for its technical assistance center. However, the grants to states are still forthcoming as they have yet to be issued. And then finally, and perhaps most importantly for children, the Bipartisan Safer Communities Act also requires the administration to essentially, I would say, do more when it comes to what is known as Medicaid's Early and Periodic Screening, Diagnostic, and Treatment, or EPSDT benefit. So I know that's a bit of a mouthful, but for those of you who are not familiar, this benefit is the essential coverage protection in Medicaid to ensure children get the screenings and services they need, including for behavioral health. However, we know the promise of this critical benefit isn't always living up to the reality on the ground, in part because of state and plan compliance with federal law. The Act requires the administration to issue guidance to states on EPSDT, in addition to requiring regular and ongoing reviews of state implementation of the benefit. The Secretary is also required to identify gaps and deficiencies, provide states with technical assistance, and issue a report to Congress on the findings. That report is due by June 2024. In addition, the Act requires the Government Accountability Office to conduct a study and issue a report by June of 2025 on state implementation of the EPSDT benefit with a focus on oversight of Medicaid managed care and EPSDT, including potential recommendations to improve compliance and state oversight of managed care organizations, as well as CMS oversight of state Medicaid programs. So again, there was quite a bit in the Bipartisan Safer Communities Act. So if you want to learn more, you may want to check out our recent issue brief we released on where things stand on the Medicaid and CHIP provisions included in the Act, and that can be found on our website. Next slide, please. Perfect, thank you. So following passage of the Bipartisan Safer Communities Act in December of last year, Congress also passed the Consolidated Appropriations Act of 2023, including a number of provisions related to Medicaid and CHIP, including mental health. I'll say again, we have a great explainer on the CCF website. However, some of the highlights as it relates to mental health include 2 new juvenile youth related provisions. So the first is a new requirement requiring state Medicaid and CHIP programs to have a plan in place to provide certain screenings and diagnostic services in accordance with EPSDT requirements, including behavioral health screenings and services to eligible youth in public juvenile institutions around the time of their release. This includes targeted case management services, including referrals to appropriate care and services. And then the second provision is a state option that would provide states with the flexibility, should they choose to take it up, to provide Medicaid and CHIP coverage to juvenile youth in public institutions during the initial period pending disposition of charges. So this is something that is generally otherwise prohibited under what is known as Medicaid's inmate exclusion. Both of these provisions, both the mandate on pre-release screenings and the state option to provide Medicaid and CHIP coverage to juvenile youth in public institutions during the period pending disposition of charges, go into effect January 1st, 2025. Starting in July 2025, the Act also included a provision requiring state Medicaid and CHIP fee-for-service and managed care plans to publish an update on at least a quarterly basis, public searchable provider network directories, including information on the specialty of the provider, whether the provider is accepting new Medicaid covered patients, the provider's cultural and linguistic capabilities, and whether the provider offers services via telehealth. This includes, but is not limited to, providers of mental health and substance use disorder services. Other provisions include new mandated guidance and technical assistance on the continuum of crisis services in Medicaid and CHIP, and an interagency task force on maternal mental health, including the Centers for Medicare and Medicaid Services, with an initial report due September 2024 and a national strategy due the following year. Next slide, please. In addition to those recent bills that have been passed into law, there's also been action at the congressional committee level this year on bills or proposed legislation touching on mental health, including youth mental health. So in July, the House Energy and Commerce Committee took up the Support for Patients and Communities Reauthorization Act. Some of you may be familiar with the 2018 Support Act, which was focused on substance use disorders and the opioid epidemic. The Reauthorization Act, which passed out of committee on a bipartisan basis, included a number of provisions, including extending some expiring provisions from the original 2018 Support Act, along with some new provisions, such as expanding required federal Medicaid reports on substance use disorder data in Medicaid, including state level data, to also include mental health data. In addition, the Senate Finance Committee held a markup on the Better Mental Health Care and Lower Drug Costs and Extenders Act last week, including a number of provisions related to mental health, such as proposed new mandated guidance from CMS to states on supporting mental health services and substance use disorder care for children and youth. So next steps on these provisions or in these proposed legislation is still a bit unclear, but we are watching closely. So definitely keep an eye out on our website for updates. Next slide, please. So in addition to action at the congressional level, as I mentioned earlier, we've also seen the administration take a number of actions related to mental health, including youth mental health and Medicaid and CHIP. Notably, in August 2022, the Centers for Medicare and Medicaid Services released 2 informational bulletins that touch on youth mental health. The first is focused more broadly on leveraging Medicaid and CHIP in the delivery of behavioral health services for children and youth. The bulletin touches on a number of topics, including EPSDT requirements, state authorities and strategies, and state examples, including around prevention and early intervention, increasing access along the continuum of care, strategies to expand provider capacity, and increasing integration in primary care. CMS also reiterates in the guidance that states can determine that some services are medically necessary for children and youth without requiring a diagnosis, providing an example of how California covers non-specialty mental health services such as evaluations and individual, group, and family psychotherapy to individuals with potential mental health disorders but without a diagnosis. On the same day, CMS also released an informational bulletin focused on school-based health, re-emphasizing existing state flexibilities for Medicaid to cover allowable services provided in schools, and providing a checklist of strategies to enhance and support such services. In the bulletin, CMS encourages states to integrate and coordinate care provided in schools with care provided across other settings and within the family unit to ensure a focus on whole child care. We've also seen CMS release other guidance documents, including on the American Rescue Plan Act's community-based mobile crisis option I mentioned earlier. That guidance also talks about the availability of administrative claiming for information technology system costs, including system integration activities in support of 988, or implementing text and chat technologies that some individuals, including youth, may be more comfortable using as part of the services offered by crisis call centers. And in July, CMS released a Medicaid and CHIP mental health and substance use disorder action plan. The action plan outlines recent administration activities related to behavioral health, along with CMS's strategies and action for improving treatment and support of Medicaid and CHIP enrollees with mental health and substance use disorder conditions. Priority areas in the plan include increasing access to prevention and treatment by improving coverage of mental health and substance use disorder screening and therapy, promoting parity and supporting integration and coordination of mental health and SUD treatment with other healthcare. They also have priorities around improving engagement in care by increasing treatment and support in home and community-based settings, and supporting access to mental health and SUD services through non-traditional settings and services. And finally, the plan also includes a priority on enhancing quality of care by encouraging implementation of evidence-based practices, improving quality measurement, and analyzing and publicizing data on key topics. Next slide, please. So as I mentioned, we've also seen some more formal rulemaking coming out of the administration related to mental health and Medicaid. This includes a finalized rule related to mandatory reporting of the child core set of quality measures in Medicaid and CHIP. So under the rule, starting in 2024, state Medicaid programs and CHIP programs will be required to report on the child core set of health quality measures, as well as the behavioral health measures of the adult core set, starting in that 2024 period. The 2024 mandatory core set of children's health care quality measures for Medicaid and CHIP includes 7 behavioral health care measures, including follow-up after hospitalization for mental illness and follow-up after emergency department visit for mental illness. CMS has also released 2 proposed rules related to improving access to care in Medicaid and CHIP in both fee-for-service and managed care. CCF's comments can be found on our website for those proposed rules. The proposed rules include a number of proposals including that state Medicaid agencies develop and enforce wait time standards for routine appointments for certain services, including a proposal of a maximum wait time of 10 days for routine outpatient mental health care and substance use disorder appointments, and also requiring state would propose to require states to conduct secret shopper surveys. The comment period has closed for those proposed rules, and they have yet to be finalized. Most recently, at the end of September, CMS released a request for comment on processes for assessing compliance with mental health parity and addiction equity in Medicaid and CHIP. That comment period is currently open with comments due by December 4th. Next slide, please. So I know I've covered a lot of different actions at the federal level, but in the last few minutes, I do want to take some time to talk about a really important topic that impacts children's coverage and therefore access to care and mental health care, and that is the unwinding of Medicaid's continuous coverage requirements. So next slide, please. For those of you who may not be familiar, in March 2020, Congress passed the Families First Coronavirus Response Act in response to the COVID-19 pandemic. This act required states to maintain coverage for most individuals enrolled in Medicaid during the public health emergency in exchange for a 6.2% point increase in federal funding. However, this coverage protection ended at the end of March, after which states were able to start Medicaid renewals, with many states, including Georgia, planning to take a full 12 months to complete all of their renewals. Next slide, please. As a result, we are currently in the midst of a major coverage event, if not one of the biggest coverage events in the history of Medicaid. According to an analysis from the Office of the Assistant Secretary for Planning and Evaluation, or ASPE, an estimated 3.9 million children nationwide are at risk of losing their Medicaid coverage despite remaining eligible for Medicaid. So we're talking about children that still are eligible, but despite that will lose their coverage. So their estimate was 3.9 million children nationwide. And unfortunately, as the unwinding unfolds, we are seeing a large impact on children. I would encourage you to definitely take a look at our data tracker on the CCF website, including state level data. So far, we've seen a net decline in child Medicaid enrollment of 2.2 million, including over 15,000 children in Georgia alone. In addition, when looking at disenrollments by individuals who are no longer eligible versus those who lost coverage for procedural reasons like red tape or paperwork, as we can see on this graphic on the right in red, a large portion of disenrollments are due simply for procedural reasons. In Georgia, after 5 months of reported data, there have been over 320,000 disenrollments for Medicaid, 86% of those of which have been for procedural reasons. So this is particularly concerning given that ASPE estimated that about 3 in 4 children losing Medicaid as part of the unwinding would otherwise remain eligible for coverage. As a result, we have seen some states, other states delaying procedural enrollments in certain instances and or taking up flexibilities offered by the federal government to implement strategies to prevent procedural terminations. Georgia has taken up some of these flexibility, but has yet to take up others. Next slide, please. With that, I will wrap up. I know I've covered a lot in today's presentation, but as I've mentioned throughout the presentation, we have a lot of great resources on our CCF website, including explainers, issue briefs, and regular blogs that highlight and break down a lot of the recent federal happenings into more digestible formats. Much of that is highlighted in our weekly newsletter, which anyone can subscribe to. It's on our CCF website if you're interested, where you can go to sign up on our main page. In addition to the unwinding tracker with state-specific information on our website that I mentioned, we also have a great state data hub with state-specific information on child insurance rates, state policy options, and even a new comparison tool that allows you to compare healthcare trends and policies between states. So with that, I'll just say thank you so much for having me here today and happy to answer any questions.
Do we have any questions? I want to thank you for this. Was really eye-opening for me. And it's always nice to see a fresh update on what's going on. And I know that there's a lot that's been going on. I've had opportunity to go meet with our senators earlier in the year to try to encourage them to stay involved with mental health reform. And we're continuing on that with that work with this subcommittee.
And I have a question. Those the administrative actions that you referenced, do those also apply to telehealth, like the required measures of implementation, such as the wait time, for example?
The wait time. I'll have to go back and double check. I think CMS generally views telehealth as a mechanism to deliver a service. And so I imagine like whether or not the actual service is delivered, regardless of whether that's an in-person or telehealth mechanism, is what they're most interested in, but can definitely go back and double check.
And also at the federal level, and Dr. Lukowitz, this is near his heart too, is there any formulary at the federal level that's been discussed?
I'm sorry, by formulary?
A medication formulary.
medication.
So what I understand from my discussion with the folks at the Department of Community Health here in Georgia, that the CMS requires that in order to reimburse for a particular medication, it has to be rebatable. And so unfortunately, the lists of medicines that are rebatable are not available to the general public. So the only way you can find out if it is to write a prescription, have the patient take it to the pharmacy or e-prescribe it there, and then they'll tell you if it gets approved or not. And also, there's also lots of individual formularies from each of the CMOs here in Georgia, and even now the Georgia Better Health Medicaid has just revamped their formulary. So several drugs that were available have been removed. So I'm not aware of a federal formulary though.
And I would like to give a plug, Ann, for your newsletter. It's terrific. And also the website is very, very good.
Any other questions? This was really a great presentation. I really do appreciate it. And I plan on signing up for some updates because I figured that'll keep me in the loop. So again, thanks so much for giving us your time and this most excellent presentation. If someone has questions about, wants copies of the slides, are you okay with me releasing them to them, or do you want to do that on your individual basis?
Sorry, release
the slide set.
The slide set. Let me double check with folks on my end,
Okay.
and I can get back to you. That sounds great.
Very good. Very good. Well, thank you so much. Let me get back to my agenda here. Oh, I know we have. Let me get back here. Oh, I'm going to stop sharing. Okay. Wow. I was really stressed, but I think I did okay. All right. All right. Our next speaker will be Miss Kimberly Johnson. And Miss Johnson, there you are.
Yes.
Welcome. And the floor, you're the director of Willowbrook Counseling Center at Tanner Medical Center.
That is correct. And I'm going to try my best to share my screen and do my own slides.
Very good.
All right. Can you see my slides?
Yes.
Okay, fantastic. All right, so thank you so much. My name is Kimberly Johnson. I'm a licensed professional counselor, and I'm also the director of outpatient services with Willowbrook at Tanner Medical Center, as you had mentioned. I want to thank everybody for allowing me to come speak to the committee today on the topic of accessing care for adolescents and their families seeking treatment for substance-related needs. Prior to sharing my presentation, I would like to share a little bit of information about my background, not to bore you by speaking about myself, but just to provide you just enough information to give you some insight into how I have come to form my perception of what I feel like is a barrier to care for the population that I'm advocating for today. So I began my behavioral health career here in Georgia in 1998 when I accepted a job at a child and adolescent residential treatment facility with having no intention of pursuing at the time a career in behavioral health care. I fell in love with the work, the children that I worked with, and the team who were all as passionate about what we were doing as I was. I loved my job so much, in fact, that I, after 2 years, quit that job. But for a good reason, because I quit to accept another position that would allow me to return to school to become a therapist and continue in the field. My new position was working with a community service board again here in Georgia. And during my 12 years with the CSB, I worked with children, adults, and adolescents, both with behavioral health care needs and substance use needs, both as a clinician and as a leader. For the past 10 years, I've worked with Tanner Medical Center, which is a private, not-for-profit hospital that is unique in that we provide an array of services that covers every level of care in the continuum of care for our small community. Willowbrook, which is the behavioral health arm of Tanner Medical Center, has a 92-bed inpatient facility with dedicated beds for adolescents. We have several partial hospitalization programs and intensive outpatient programs, including our Regain program, which is a substance use intensive outpatient program for working professionals. And in our outpatient settings, we have counseling clinics, psychiatric clinics, intensive family intervention programs, and a very robust school-based counseling program. So with my background and in working with the Community Service Board, all the policies and decisions we made were directly connected with the policies and service guidelines provided by the Department of Behavioral Health. Willowbrook is also unique in the fact that our policies, of course, are guided by hospital guidelines and accreditation bodies related to being a hospital. But because we also have some programs, our inpatient facility and some of our outpatient programs have contracts with the Department of Behavioral Health, that some of these programs have additional standards. And I'll discuss in a few slides down how having hospital standards overlaying with DBHD standards can prevent some barriers and a double set of standards for the individuals and families seeking treatment. Also, before I jump into my actual presentation, I also want to share with you guys that I do understand that DBHD sometimes gets a bad rap when it comes to extensive policies and service standards, but I do want to assure this committee, as well as anybody that's on from DBHD, that I'm not here to undermine or to criticize the department or their policies. As someone who grew up clinically and professionally in the DBHD world, I'm very grateful for my experience, and I have a healthy understanding and appreciation for the intent of standards that were created to ensure the safety and clinical integrity, as well as consistency of care throughout the state for the individuals that they serve. However, like medication, where we must consider risk versus benefits, occasionally we run across a rule in which the risk to the individuals we serve outweigh the intended benefit. So I apologize. I tested this and it was skipping slides, and then I thought I had it fixed. So let me play with this to make sure I stay in the right spot. There we go. So I'm not going to spend a lot of time on this slide because I know that no one on this committee needs to be convinced of the need for substance use treatment. However, I will say that when I researched the statistics for substance use by adolescents in Georgia, I discovered that Georgia, comparably to other states, does have a considerably lower rate of adolescent substance use. However, when you look at how Georgia ranks in the area of access to care, you will see that Georgia ranks 49 out of 51 when also counting the District of Columbia. As exciting as it is that maybe comparably to other states, we have a lower use of substances with our adolescents, I have no doubt that having a lower national average of use for adolescents is of no consolation for families being directly impacted and seeking treatment in the state where there are so many barriers to treatment. The barrier to access and treatment that I really want to focus on and want to share with you guys today is within the regulation governing drug treatment and education programs. And I do want to pause for a second and hover on the title just long enough to emphasize the wording treatment and education programs. In the next slide, I will show more information about the difference between treatment programs and education programs, as well as the different levels of care. But for now, I think it's important just to be aware that this is a blanket rule that covers both treatment and education programs. The specific rule that I'm focused on today is guidance on what is required in the initial assessment prior to allowing an individual to begin or to enter the treatment program. So there is information before and after what you see listed on the slide, but I'm specifically focused on the wording listed on the slide and specifically the requirement for TB and STD testing. So TB testing, of course, it requires an individual to participate in the test, which must be performed by a medical provider, but can be completed at the time of admission if that medical provider is immediately available. However, the barrier lies in the requirement that the individual must return within 48 to 72-hour window to have the TB test read by a medical professional. If this time frame is missed, of course, this process starts all over again. Outside of this regulation, DBHCD has a policy that requires an admission to be scheduled within 0 to 2 business days from the time an individual requests treatment, with a preference for completing the assessment at the time the individual reaches out and asks for help. The policy was created knowing that any delay past the time a person was motivated enough or in enough of a crisis to ask for help increases the chance that that individual will not return and seek treatment again. So for individuals with substance use needs, it is great that we can begin the process of providing help the moment they reach out, but delaying the start of treatment based on their ability to follow through with returning within that 48 to 72-hour window is unrealistic. It is often difficult and a delay in individuals and families reaching out to begin the process in the first place. The second requirement that you will see in this regulation and this rule is the requirement of STD testing. And you'll notice that it's vaguely worded in this rule. So the guidance that we're given as providers comes from the accreditation body, the Drug Abuse Treatment and Education Program, or DAPAP, that falls within the Health Facilities and Regulations Division. So this is an accreditation body that all agencies contracted with the department are required to have and ensure our compliance through on-site audits of medical records to verify that all individuals have had these tests completed prior to beginning treatment. Their guidance on the STD testing states that the standard is met by the completion of an RPR test, which of course is blood work. So again, if a medical professional is immediately available, this can be done on site without the need to make a referral. However, like most medical facilities now, even my PCP no longer does their own lab work on site. They refer out to a lab. We are not a medical provider, so we also contract with a lab. And then we're held hostage to hoping that individual shows up for that blood work, hoping that we get that lab work back and we get it back in a reasonable amount of time for the individual to begin treatment. Outside of that, there's also the additional awkward conversation that we as providers must have with a family who is dealing with what is the most likely for them, the most devastating thing that they've had to manage for their child, and inform them that before their child can begin a telehealth education program about drug abuse, that they must be screened for syphilis, because that's what the RPR test is screening for. So this slide shows us different levels of care for substance use treatment. The American Society for Addiction Medicine provides this structure we refer to as the ASIM levels, and it's been around for a very long time. We use this guidance to determine, after a thorough assessment has been completed and we have a better understanding of the depths of an individual's needs and their motivation for treatment, what level of care best fits their needs. So if we look at the right-hand side first, starting with level 4, which is described as intensive outpatient, this is our psychiatric hospitals, which are short-term, medically managed 24-hour care facilities. Then when we move over to level 3, these are our residential programs that are also 24-hour programs, and for adolescents would encompass our psychiatric residential treatment facilities, or our PRTFs. So level 2 is our intensive outpatient and partial hospitalization program. These are programs in which individuals receive a similar level of counseling and medication monitoring as they would in a residential or inpatient program, but are not 24-hour programs. Instead, adolescents would attend 4 to 5 hours of treatment a day and then return home to sleep in their own beds and be with their own families in the evening. And then level 1 is our basic outpatient counseling program. So these are outpatient substance abuse groups that can either be in person or attended via telehealth. Prevention and early intervention programs or education programs, and these two can be face-to-face as well as provided via telehealth. So as I mentioned earlier, the regulations are currently blankly applied to all the programs, including the programs of the lowest level of care, in which there's no contact between individuals attending the program and in which there would be no concern for communicable diseases. I also want to take a moment to point out that this rule also applies only to individuals seeking substance use services, providing them an additional hoop that is not applicable to individuals seeking behavioral health services at the same facilities. Second, to the inconsistency between individuals seeking treatment for behavioral health needs versus substance use needs, I also wanted to highlight the inconsistency between individuals seeking care based on their payer type. I mentioned regulatory bodies for private facilities versus state contracted facilities. So in Georgia, an individual with private insurance or the ability to self-pay for treatment has options to seek treatment with an individual in private practice, with private facilities or a private hospital that are not required to be accredited by DAPAP and therefore do not have these requirements. However, individuals with Medicaid, whether they're managed by DBHCD or by a care management organization, or individuals who are uninsured and are seeking services through a community service board, who I would argue are already at a disadvantage for seeking treatment due to economic and oftentimes transportation barriers, are the individuals with the additional hoops to navigate for treatment. I was curious as to how much this impacts the adolescent population in Georgia as a whole. And based on the data I found that is presented on this slide, I found that 46.5% of children are covered under their parents' employee-sponsored commercial insurance plan, compared to a combination of 46.3% of children having Medicaid or being uninsured. So this is the disadvantage for seeking treatment that impacts half of our adolescents in Georgia. So in conclusion, these are my recommendations. There is presently a form being used by the Georgia Department of Public Health to screen for the need for TB testing. So my recommendation would be to not blanketly require TB testing for all individuals, but rather to modify this form to be used by non-medical professionals, but by professionals who are qualified to complete substance use assessments, either based on being licensed in the state of Georgia or being nationally certified as an addiction counselor. I recommend for SEP testing that this also be eliminated as a blanket need for all individuals seeking treatment, and instead be required on an individual basis when, quote, clinically indicated. And I say quotes because this is already written into the language of the rule for all other lab work other than TB tests or STD testing. It's written that it's only to be performed, or it can be performed when deemed necessary based on the assessment of the individual, not necessarily for every participant. Again, thank you. I appreciate you, your time, and I appreciate you allowing me to present this regulation and the barriers that we face when working with our adolescents and trying to help them and their families navigate the system. And I'm open to any questions if you guys have any.
Thank you very much. And I know our commission member, Gwen Skinner, has talked to me about this before. So this is not just affecting you at Tanner Willowbrook, but also at Devereaux. And so, and I know I have a background in microbiology and immunology, and so I would say that I don't have any issues if they're not in contact. I don't see any reason that you need if you're doing virtual education. There's no benefit from this. I mean, I think it's intended for where there's contact between patients, and there is an increase in rate of tuberculosis and treatment-resistant tuberculosis. So it's not an insignificant problem. There is also a resurgence of syphilis in the community, and treatment-resistant syphilis as well. So in situations where there are patients in contact with each other and there's the possibility of spread, I don't know, I think there's going to be a lot of pushback, but in the situation that you're describing, I don't think there should be any.
Yeah, and I would recommend, if we didn't want to remove the requirement altogether and base it on a screening of need, then at least our lower level cares, not just telehealth, but our, level 1 and at least level 2 and possibly level 3 treatments. If we are nervous about pulling that out completely, I think my preference, and Gwen, you work for PRTF, you can tell me what you think, but it may be more appropriate in a PRTF setting, but definitely not in an outpatient or intensive outpatient setting.
Well, I think the reality is that if we create barriers to children getting into treatment for substance abuse, when we know how everything that brings with it out in our communities, it makes sense to me if we create that, we act like if they're out in the community, they're not going to be spreading the disease, when they're less likely to spread it if they're in a facility where they're receiving treatment. So I don't know where we can, I absolutely believe it doesn't make sense to do it for these lower levels of care, but I also think we need to look at when is it appropriate to do it without making blanket? When is it appropriate? Because as a private family, if I put my child in substance abuse, they aren't going to require me to do that.
I agree. It really is a institutional bias against folks that cannot afford to go to a private provider. Not to mention the fact that it is overwhelming for a family, especially with adolescents, to hear the standard and to follow through with the standard.
Yeah.
So it really would be my preference that we take a form that already exists in Georgia, create a decision tree that would be appropriate for non-medical providers, and use the same standard that we're doing in our public health departments.
And Kimberly and Dr. Lukowitz and Gwen, what about other states? How do they handle this issue?
That's a great question. I don't know the answer to that, but I'm happy to do a little bit of research and see what I can find.
And I agree with you all that if it's not required in the private setting, it shouldn't be required in this institutional. I mean, that makes no sense. It should be the same rule across the board. We don't discriminate.
Right.
And
create a barrier for people of lesser means.
And we already have enough barriers as it stands.
Exactly.
And when we look at other states too, I suppose it'd be important to find out, is it in state statute or is it in DPH board rule? That might make a difference too when we look at other examples.
Kimberly, I can work with you on that since Deborah's in, several states, but this has tremendous support among the provider community because it's not a Devereaux issue, it's a provider issue, and people want to provide the services. But I absolutely agree with you, Dr. Lukowitz. If it's not a rule in the private sector, then we shouldn't make it a barrier for others.
And I'm not putting any pressure on you, Kimberly and Gwen, but if we want to include this in this year's annual report, we would need to have, right, Dr. Lukowitz, we need to have that really pretty soon. If you could just do a quick scan of other states, just as a reference point for this issue.
Yeah, I'd be happy to.
You word it, Kimberly, and I can put it out to several states.
Okay.
Okay. Well, very good. Any other questions? With
Well,
that, I'd like to
go ahead.
Thank you, Kimberly. I'd like to welcome again our friend Wendy White-Tegreen from the Department of Behavioral Health and Developmental Disabilities. And you were going to talk about the organizational system of the DBHDD, but I will let you take the floor and tell me what you're going to talk about.
Thank you, everybody. Can you hear me okay?
Yes.
Excellent. And I can't start sharing until this one comes down. It just told me. So, Kimberly, if you
Yes,
don't
and
mind.
I'm trying to figure out how to do that, Wendy. Give me 1 second.
That's okay.
There should be a button at the top that says stop sharing.
Yes. And I can only see one that says new share.
I will, just to try to help Gwen and Kimberly quickly. I will say that the DTAP regulation in Georgia, it's with the DCH. The healthcare facility regulation is under DCH. And it's not that it doesn't apply to private providers. It's just, it was a programmatic rule that the TB and the STD was a programmatic rule for when people are gathered together in congregate settings. So then individual practitioners are not required to go through that licensing because it's a one-on-one scenario and it doesn't create the potential for large-scale communicable issues. And so I just wanted to kind of be sure y'all are refining that if you're thinking about it for a recommendation, because a private provider, it definitely applies to if it's having group and congregate settings. But I mean, I can see your point about, well, if you're doing virtual, that probably just needs to be updated for new technology. So I'm not getting in the weeds there with you guys. I just wanted you to know kind of how I was fine tuning that little private versus public thing. And again, that's all under HFR, under DCH, but just based on my longstanding lens on having to deal with that reg. Just wanted to be sure y'all kind of captured that refinement if you're moving really fast.
Thank you, Wendy. I appreciate that.
Yeah, for sure. Okay, guys. So let me just tell you, the reason I'm here is that Dr. Lukowitz and Dr. McGivney and I were going back and forth in preparation for my presentation that I did for you guys last time. And one of the questions that just came up was from Dr. Lukowitz and Dr. McGivney was like, yeah, we still kind of don't understand the way DBHDD organizes the provider network. And so I said, well, I'm happy to just give that a go. So I'm not going to take terribly long with you guys. And I think you probably, if y'all are all watching the work that's emanating out of Medicaid right now, the times they are changing. And I'm not going to speak to that. I'm actually under a non-disclosure agreement in partnership with DCH. And so definitely cannot talk in any way about that procurement, but I think things, I'm going to get it hopefully as clear as possible for all of you. And then just giving you kind of the heads up, it's all changing and pivoting. As fast as the system can possibly go, it is morphing. So just wanted to kind of put that context in play. And I hope y'all are kind of tracking and watching that and learning about it. But not for me right now. Another time perhaps, but not for me right now.
Wendy, is that still open for public comment?
Public comment happened last summer of 2022, where you could provide feedback. The procurement is still open. So the bidders they have until it's November 30th or December 1st. So, a couple of weeks from now to submit the bids and then those will close. So
I'm sorry. I guess I was also talking about the CMO. Is that still open for public comment? The care managed organization or
the procurement is, it is finalized. It is released. And the bids are being worked on by potential vendors right now. So there's not really public comment on that because it's already a document that's already in place that has been released. So yeah, the chance to kind of comment on what would be in it was summer a year ago, summer of 2022. So bids are coming in, and they'll be in a couple of weeks. So, so again, things are changing. But I'm going to kind of talk to you about the way DBHDD organizes its provider network right now, so that you can kind of have a better understanding of this. Except for, there we go. I was about to say it didn't want to let me advance. Okay, so DBHDD has kind of 3 categories of providers that it works with for behavioral health. And we use the term behavioral health to be encompassing of mental health and addiction. So when we talk about behavioral health, that is mental health plus substance use treatment and recovery supports. So this is just a graphic. To me, it's not laid out super clear. So I'm going to unpack it in the next couple of slides, so that you can have a better understanding of it. But basically 3 tiers of providers. And I'm going to this is kind of the overall graphic, but it gets a little easier when you can dissect it like this. So tier 1 providers for DBHDD, really these are the community service boards for us. And they are, of course, quasi-governmental, and they are very comprehensive in nature in accordance with how they are defined in the law and how their funding flows and the like. But basically, we say for each CSB, each tier 1 provider, they actually function as the safety net for DBHDD's target population. And our target population right now is the state-funded folks. So if they're indigent and uninsured, or Medicaid under the Medicaid rehab option. So the Medicaid rehab option is one category of Medicaid services in Georgia. There are dozens and dozens of categories of service, but it's one that is a comprehensive behavioral health service array. And it is the array that we jointly manage with the Medicaid agency. And we define a giant array of content in it, from really traditional stuff like psychiatric assessment, all the way to like peer support programs, psychiatric rehabilitation programs, addictive disease recovery support services. So really flexible, non-traditional services, as well as many traditional services. And then again, what you all should understand a little bit of is that we also kind of serve as support services for the underinsured. Now, I know the first parity law passed in 2008. I know the second reinforcement of parity passed with the ACA. What I do still know is that private insurance has levels and bands of coverage. So you have different benefit levels. You'll remember people talking about the silver and the bronze. So sometimes these are comprehensive packages and sometimes they aren't. Often when children and young people need a service that's not covered by their insurance, DBHDD will come in and be kind of almost like a wraparound plan for those beneficiaries. The thought is that after 4 to 5 years post parity law passing, that role would diminish. We're not there yet. I really want to be there. We're not there yet. And hopefully House Bill 1013 starts to get us a little closer to that when it reaches its maturation in Georgia. But I think folks are still understanding parity through a set of lawsuits across the country and what's really going to be expected from that. So we do still cover the underinsured. When we talk about a tier 1 provider, they have to serve adults and youth, and they have to do mental health and addiction services. Those are the providers who we target with crisis services. So if you look down in the lower left corner, we really try to, in all cases where possible, to begin dialogues with those providers about them being the home for crisis stabilization units, behavioral health crisis centers, or the crisis walk-in centers, the 24/7 walk-in centers. And we require in the bottom right-hand corner for them to at least have their toe in the water with some type of assertive recovery support. So they have to either do psychiatric rehabilitation or have a peer support program in that first column. Or in the second column, you have to be doing assertive community treatment, community support team, or intensive case management to really be prepared to, in some ways, lift themselves up for really high acuity service and support. So for each of these categories, these tiers, then we have a set of standards. And we have a set of KPIs, key performance indicators that we monitor on an annual basis for each of these provider types. So again, I think most of these things I've already hit on here in my dialogue, but it's public entity. Again, the CSBs are public. They serve as a safety net. They serve all ages. They have to have a solid EHR. They have to serve behavioral health and developmental disabilities. So many folks have co-occurring needs that was a crucial aspect to our policy setting. Again, they have to do mental health and addiction. They have to do all of the basic core services, which again include that whole array: doc, nurse, diagnostic assessment, service planning, individual counseling, family counseling, group counseling, community support, which is kind of like a case management skills building for kids, and then some of these really high acute specialty services so that we know they have capacity to serve really the most in need, have an active board of directors, have accessible services for deaf and hard of hearing individuals, and serve as a clinical home. So they are going to take responsibility for all of that person's behavioral health needs and coordinate. So even if somebody decides to go see like a private psychologist who stands alone, maybe in an insurance plan, excuse me, then they also have to coordinate that to be sure it's integrated, serving as a behavioral health home. Okay, tier 2. And pardon me again, I stayed with my mom last night and she had a cat and I'm apparently allergic. Sorry guys, I hope that went loud for you. Wow. Okay, tier 2. So children, so this is a different category. And these providers have to provide all core services. Sorry.
Why don't you go get a drink of water and come back right back?
Y'all, I apologize. Woo. Okay. Okay, I'm gonna try this again. So community Medicaid providers, these are Medicaid only providers. So DBHDD, we don't have enough state money to pay for a whole cadre of providers where we just don't have enough money in the checkbook because, excuse me, the greatest predictor of utilization is really to have more portals of access. We want more portals of access, but there's not been a big infusion of funds. So we have a way of inviting providers in to use the Medicaid benefit package and have them provide all of those core services I named but they're Medicaid only providers. So you see the factors at the bottom, what they do, we go through a rigorous screening process, but they are Medicaid only. So they're like a tier 2 provider. They can be a for-profit or a nonprofit, and they serve only Medicaid covered lives. That makes sense. So it's just like the core, kind of, not as rigorous, but they only have access, being approved through DBHCD, to kind of a certain payer source, which is the Medicaid bucket of money through the Medicaid rehab option. Okay, and those providers, they could serve children, adolescents, emerging adults, or adults, so they don't have to do it all. They have to do mental health, SUD, and co-occurrence. They still have to have all that capacity and infrastructure. They still have to do deaf and hard of hearing services and have culturally, linguistically competent approaches. And then there's a third type of provider, which is a specialty type only. So we have specialty services that are real niche. And some providers may just do one box, one of these little sub boxes. Some providers may do multiple of these little sub boxes. So you may just have somewhere sitting out there a provider who does just psychosocial rehabilitation. And that would be fine with us. We will vet you against those standards and approve you. Or you could do psychosocial rehabilitation and be an assertive community treatment provider. Or you could be doing all of these little sub boxes in addition to being one of the tier 1 and tier 2 providers. So both of these models show that. So that's basically it in a nutshell. So I will take questions from you guys and see if this kind of helped you understand the framework.
Okay, that really does help me understand, like, what's the purpose. And I mean, I kind of figured that it was an attempt to expand access. I figured that as much. And I, just for disclosure purposes, I do some contract work with one of the tier 2 core service providers. And so it's just interesting that the I'm sorry, I didn't realize I was muted. So this really does help me. I understood that probably the reason was for this institution of this was to expand access, because you can't possibly deliver services to everybody with just DBHTD. And so I want to just make sure you know, I do some contract work with one of the core 2 providers, and the rules are very different. So even the CPT codes are different, and the times that you spend with patients and the reimbursements are vastly different than what they are.
Not for DBHDD, they're not.
Well, so
I mean, I will tell you, like, I do all the coding for the department. It's identical.
But the coding that we have, like I'm at the Medical College of Georgia, we use the AMA CPT time-based and also complexity codes, and the core service providers, we bill like 99212 for between 13 for 0 and 13 minutes for a 99212. That would probably qualify for 99213 in another setting. So I don't understand that part, but that's not really why we're here today. What I'm curious about is, are there any non-CSB tier 1 providers in the state?
No, we do have what we call the tier 2 plus providers, and that's about half a dozen providers who, because of like a real niche, because like they're almost tier 1, but they far exceed the tier 2 standard, that we work with them, and it's just kind of a little midpoint. So like Grady. So
Right,
think
right.
about Grady, they are, you know, a municipal public sector vendor. They are comprehensive in nature for adults. You know, we couldn't get by without them. We want to give them state money. And so they are what's called a tier 2+. So there's some real tiny niche providers like that who are so comprehensive in nature, have a lot of public funds invested in them that we work with in that manner. So Grady's the best example of that 5 to 6 types of providers
And I
who we
listened
give a
to-
plus status.
I listened to Dr. Fitzgerald's subcommittee meeting where they were talking about the application process and how it's rather onerous, 37 pages, and typically takes about a year and a half to be approved. And they're trying to make it a little bit less onerous and not take so long. So, but there are differences in the reimbursement rates. Even so, as it stands, core service providers who see Medicaid patients actually get reimbursed at a higher rate than would even a private insurance company in another setting.
Oh, I can guarantee you that.
Yeah.
So
So-
let me just speak to that quickly.
Sure.
The Medicaid public sector rates also have this overlay of getting, of our department receiving SAMHSA funds. And SAMHSA has what's called the TEDS and the NOMs, and those are like all these outcome items. You have to report on them, like every single person who is touched. You have to report all this data. It lowers the practitioner's productivity, right? Like if I have to know whether or not you're a couch surfer, you're officially homeless, you're on the verge of homelessness, if I have to do that kind of fine detail to submit to the federal government, it takes longer. So my productivity then as a clinician is lower. Like I can't see 10 people, I can only see 7 because I've had to ask you many more questions than the private sector does. So we and Medicaid for the Medicaid rehab option typically pay more than the private sector. And when to your question earlier, the Medicaid rehab option and state funds, those things are identical codes, identical rates, and identical rules. But they are different sometimes than the private sector because we are adjusting for these things, the weight of the administrative burden that comes with this. So very much like we were hearing from Kimberly earlier, like there are these administrative burdens. And again, I'm not agreeing like the telemed and STDs and TB, like that defeats the whole purpose. Like it's good about being together like 20 people and not spreading TB to 20 people. I get that. In the times of telemed, that's not like realistic anymore. Or even, it doesn't even seem like it's comprehensible to apply that to that type of thing. But we do lay on a lot of expectations in the public sector because of funding streams, because of reporting, because of accountability. If so, we sometimes have to pay more. And so most states in the union are envious of Georgia's rates. We are right at the cusp of being kind of right at the brink of being in the top third, depending on kind of the timing. We break almost at that 1/3 top of the country, being in that top 1/3 and the top of that second third in rates. And we are asking for more rates because we haven't had a rate adjustment since 2008. And the salaries that we are reimbursing are just extraordinarily low. And so it is time for a rate adjustment for our system as well.
And I saw the results of the salary survey, and those are like, it's mind blowing that they're so low, and people are leaving jobs in mental health and going to work at Starbucks. So because they can make more money. Yeah.
Of course they are, but just everybody be aware there's a rate study that's floating out there. So we would love for you to learn more about that and be able to indicate whether or not you're in support of it based on your own personal lens on it.
Well, we need more people in the workforce, and unless we pay them more, they're not coming.
Don't disagree with that.
So one other thing, which I think is important, there seems to be the capability of billing for some case management through this, which is
Oh, yeah.
not possible in the private setting.
Right.
And so
Yeah.
that's a really beneficial for some of these families with really complex social situations.
Yes, we have reimbursed case management as long as I've been with the department, which is since 1995. So case management has always been reimbursable for children, adults, and individuals with addiction
And I'll give you
concerns.
an example. I have a patient that I see who the mother, it's actually adoptive mother, is illiterate. She's from the islands, so she can't read. And so she comes to me, and I asked her if she had had her son vaccinated for COVID. And she said, no. I said, well, how come? And she says, I don't know how to do it because you have to do it online, and you can't do it online if you can't read. So I actually never thought I would do this, but I did it anyways. I asked her, where do you live? And I said, is there a pharmacy near you? And I found out the pharmacy. I went onto their website. I said, when can you make an appointment at this time on Saturday? And they said, yes. She said, yes. I said, okay, go there at this time on Saturday. I signed her up and he got vaccinated. So that was a proud moment for me.
You case manager at heart, Dr. Lukowitz.
That's correct. That's right.
Yeah. Okay. Yeah. Any other questions? Again, this was just a follow-up from Dr. McGivney and Dr. Lukowitz with me. Just we still can't get our heads around the provider network thing. So can you come and talk to us a little bit more about it? So
well, thank you so much. As again, this is very enlightening and really helps me understand the system and why. And I kind of gleaned from my experience what the reasons were and the benefits, but this sort of confirmed what I suspected. I think Wendy's frozen. Anyway, do we have any other questions? Okay, well, I think we're just about at 5:24. I thank all of you for your participation. This was again a very enlightening session, and hopefully we'll get some recommendations to Anne and her folks and to the full committee on December 6th. So again, thank you so much, and happy Thanksgiving and Merry Christmas.